Bismillahirrahmanirrahim. Now we have case quiz number 27, and from this day and the next cases, we will try to speak only with English to enable people and followers from anywhere around the world to follow us easily. So we will try to avoid Arabic explanation as much as possible. Case data: 46 years old woman with 3 months history of rash during summertime. By examination, she had vital signs are normal, BMI 23. She had eyelid swelling and a periorbital violaceous rash, erythema and poikiloderma of the anterior chest and upper back, and erythematous papular rash on the hand, with no malar eruption, skin thickening, or digital ulcers. Muscle strength and reflexes are normal. Guttrum papule over the extensor surfaces of the small joint of the hand are seen. Investigation show normal CBC, CBK 100 which is normal, aldolase 5.1 which is also normal. ANA was positive speckled with a titer 1/640. ANA profile was negative, urine analysis normal, EMG was normal, and finally muscle biopsy is not done. So what is the diagnosis? Yes, you are right. The diagnosis is amyopathic dermatomyositis, which is dermatomyositis without muscular involvement. Amyopathic dermatomyositis refers to dermatomyositis with cutaneous involvement in the absence of clinical laboratory electromyogram, EMG, or biopsy evidence of myositis. This patient has a clinical presentation of heliotrope eruption in the form of violaceous periorbital rash, guttrum papule over the extensor surface of small joint of the hand, and foot-distributed violaceous poikiloderma, V sign and Chow sign without muscle weakness. There are findings of skin involvement seen in dermatomyositis without any clinical serum or electromyogram findings of muscle involvement of myositis, suggesting that the diagnosis is amyopathic dermatomyositis. Amyopathic dermatomyositis is seen in about 20 to 25% of patients with dermatomyositis, but some of these patients have evidence of myositis on one of the evaluation studies, such as muscle enzymes, EMG, or muscle biopsy in the absence of muscle weakness clinically. To qualify the diagnosis of amyopathic dermatomyositis, the patient should have the characteristic rash but no clinical laboratory or muscle evaluation findings of myositis. Amyopathic dermatomyositis may be triggered by sunlight exposure and also is associated with an underlying malignancy. Treatment is usually with glucocorticoid and immunosuppressive drugs. There are some differential diagnoses of this case. The first one is polymorphous light eruption, PMLE, which is another dermatological condition in which the patient develops skin lesion after exposure to sunlight. These lesions last several days and resolve spontaneously in the absence of re-exposure. A variety of skin lesions may be seen in PMLE, including arterial wheals, papules, plaques, and vesicles. PMLE usually develop early in the spring, with the first few exposure to sunlight, and can be triggered by intense exposure. These lesions occur in photo-distributed areas but lack characteristic heliotrope or guttrum eruption. Another differential diagnosis is rosacea, which is a chronic inflammatory condition that causes an acneiform eruption and flushing on the mid-face. There are two types, vascular and papular pustular or inflammatory rosacea. Vascular rosacea present as persistent flushing, especially in the central face with prominent telangiectasia. Pustular and papules are seen in the inflammatory variant, but in contrast to acne, rosacea pustules are not follicular based. The patient findings are not consistent with rosacea. Although this patient has positive antinuclear antibody, she lacks associated findings of systemic lupus erythematosus, including malar or discoid rash, arthritis, organ involvement, and kidney disease. SLE can cause rash on the hands similar to Guttering papule, but it is more typically involve skin located between the joints. And finally, thank you very much for your attendance, and we hope to see you in the next case quiz. Wassalamu alaikum wa rahmatullahi wa barakatuh.